Here we are. So they use. We have already heard about the usage of green of the pulsed light, but let me talk about the intense regulated pulsed light as produced by a French company, because each specific kind of pulsed light has its own protocol for use. They're not exactly the same, although the principle is the same. So the system of the ocular surface is very complicated. One shouldn't only consider the film, but also mammalian glands and the whole immune system and so on and so forth. And because these systems then trigger the local responses, because we know that the ocular surface system, which is so complex, is continuously stimulated by environmental, endogenous as well as exogenous factors until we get a sort of homeostasis and correct response. Everything is balanced. But when this fails, the dry eye develops. Dry eye nowadays doesn't really mean TLS, dry eye, but a disorder or disturbances, a disturbance of the tear film, which is accompanied by some subjective factors, but also two important factors, hyperosmolarity and inflammation of the surface. What we try to do is when we have a patient complaining about this disturbance or disorder, we can consider the aqueous component, or there might be an excess of evaporation, very often also associated with a dysfunction of the meibomian gland. What we do know is that both in the case of a deficiency of aqueous or the components of the tear are altered, we, however, will have a hyperosmolarity accompanied by inflammation, and that's what triggers a vicious circle that we should try and interrupt by means of our treatment. So now we should try, okay, to make a correct diagnosis. We should first of all identify all the tests, the slit lamp or subjective on the basis of our experience, as well as instrumental tests, as you may see in these two slides, that may allow us to diagnose the disease and to check whether the patient, who sometimes is difficult to classify within a specific group, there might be overlappings, but once we classify or try to classify him or her on the basis of these tests, then in the end we should decide what is better, or what treatment would be better for him or her. This is graphic images. So here you may see what we know in order to evaluate the thickness of the lipid layer. Once we have the diagnosis, we can take, we classify our patient as an evaporative patient. We can treat him or her, so I think that it should be 360 degrees. So there should always be a medical treatment combined with an instrumental, let's define it in this way, and now I will define it, which is intense regulated pulsed light. So usually my patients, especially at the beginning, I prescribe general and broad treatment, including hydrocortisone, depending on whether there are other eyelid problems. And then I administer intense regulated pulsed light to have a durable outcome. So this is what I do in patients having a dry eye sensation, but sometimes even in excess of tears, or chronic blepharitis, or blepharoconjunctivitis, altered function of the meibomian gland, and a disorder of the tear film, and or patients having cutaneous problems, rosacea, or other disorders affecting the eyelid border and who are on steroids or assume or taking using tear substitutes. So how does this what's the principle on the basis of which the IRPL works? So by stimulating the glands and indirectly, i.e. the parasympathetic nervous tissue, by stimulating indirectly the glands in order to have them release the lipid component of the tear film. So this is a xenon flash lamp. This is the wavelength and also the energy and frequency you may see on the slide. So determining the action delivered or the energy delivered by the machine. And then if you allow me one more minute, I'm going to show you the functioning principle of this equipment or machine. So, of course, this is a puppet. You can see that the eye is continuously blinking, and the component of the mammalian gland is continuously squashed and pressed, and then there isn't any adequate protection of the tear film because it doesn't stay for a long time on the surface of the eye. So this device stimulates the glands in this way, and by stimulating the glands at any blinking, more lipid component is released, so the tear film gets more stable, so the lipid layer is thicker, it stays for longer on the ocular surface, so less blinking and a wider and clearer eye, a less inflamed eye. So 3 sessions should be administered at 15 and 0, 15 and 45 days distance. And where are the spots applied? We start from the root of the nails, going temporally, and so it's 10 spots for each individual session, and in all cases, so it's more than 500 treatments I have performed. The protocol hasn't been changed. So this is our case series, over 500 treatments, and 150 dropouts, but 77% of patients were very happy, and you may see here the satisfaction rates. These are the questionnaires, and so the inflammatory test, osmolarity, and so on and so forth. So a happy patient is a patient who received a benefit from all these exams. So reduction of the OCDI value, a significant reduction of osmolarity, inflammatory test became negative, and higher value of the NIBAT. And on the first 12 subjects, we have assessed osmolarity, and in this way, we proved that this pulsed light actually succeeded in reducing osmolarity in these first 12 patients. The higher the initial value, the higher the outcome, or the better the outcome. And here we have proven the efficacy of our method in increasing the NIBAT value, and also the lipid layer statistically significantly, and maintaining the same percentage of functioning glands, because and reducing the symptoms. So in conclusion, to be sure, IRPL is a safe and effective treatment. It should, however, always be associated with the medical or combined with the medical treatment, and the outcome can be optimized with a good pre-treatment diagnosis. Thank